Hi, Sarah. Thanks for being with us today. As you know, I have some questions for you. Can you tell us a bit about yourself and your professional background?
Yes, so as you mentioned before, I'm a director at the American Society of Pharmacovigilance. My background is in pharmacy. I'm a pharmacist. I received my doctorate in pharmacy from the University of Houston College of Pharmacy. Graduated in 2012. From there, I worked at MD Anderson Cancer Center in the ambulatory transfusion unit. So basically, all of our patients were receiving IV chemo, and my area actually specialized in investigational IV chemo. So majority of our patients were on study protocols. And while I was at MD Anderson, became board certified pharmacotherapy specialist, and I got really interested in an area of study called pharmacogenomics, which is basically a laboratory test that can be done to kind of give clinicians an indication as to how patients metabolize drugs, and it could be help to clinicians to select an ideal drug for a patient that's more likely to be effective and less likely to cause side effects. So in learning more about that area of study, I became really aware of what a huge problem adverse drug events are. So most people don't realize this, but adverse drug events are the fourth leading cause of death in the U.S. It costs the U.S. health system $136 billion a year, which I think is an underestimate, just because not all adverse drug events are caught, essentially. And it's causing millions of emergency room visits and hospital admissions. So a group of us came together and we started the American Society of Pharmacovigilance, which is a nonprofit organization.
Wow.
Yeah, definitely. And we are, just to give you more info about the organization, we are a national biomedical and healthcare network that is open to all healthcare professionals.
What type of work do you do at the American Society of Pharmacovigilance?
So our mission is to rapidly and dramatically reduce the high rate of suffering and mortality of adverse drug events in the U.S. So I think our first goal is really just to create a platform for healthcare professionals to come together, to create a multidisciplinary group to kind of attack the problem at all angles. And my kind of day-to-day activities center around awareness of the issue and also education and training, because pharmacovigilance and especially pharmacogenomics isn't something that all healthcare professionals are trained on, especially with pharmacogenomics being a newer area of study, maybe something that people haven't implemented yet. So we do work a lot with creating awareness about pharmacogenomics also, especially as being used as a tool to prevent adverse drug events. We're also working to create an open access journal, medical journal in pharmacovigilance, to promote research in the area. And we are also planning to put out essentially an adverse drug event annual report that showcases the state of ADRs in the U.S. and summarizes all the current literature. So those are some of the things we're working on right now.
That seems like a lot.
It is. It really, as we go forward, we realize more and more just how big the problem is. So.
Wow. Now, what exactly is pharmacovigilance?
That's a great question, because I feel like a lot of people outside of healthcare aren't really familiar with the term. It is basically, pharmacovigilance is any effort to track, monitor, or prevent adverse drug events. And more than that, there's certain words or jargon that's used to describe pharmacovigilance that even in healthcare are being misused or not used precisely. So pharmacovigilance, maybe people might think of medication safety or a medication error. So for example, the doctor prescribed lisinopril 5 milligrams to a patient, but the pharmacy delivered lisinopril 10 milligrams to the patient. So that's a medication error. But not all medication errors result in adverse drug events. So maybe by happenstance, lisinopril 10 milligrams was a better dose for that patient. So that's one thing that we try to definitely get out there, is the differences in nomenclature and using these terms correctly. And also just prevention of serious side effects too. So because an adverse drug reaction is any unintended any unintended effect of a medication. So that includes side effects, and I think most pharmacists, if you say like, what's an adverse drug reaction? Well, oh, it's a side effect of a medication, which it definitely is, but it's any unintended effect. So when we prescribe the medication, we're intending it for it to work. So if it's ineffective, that's an unintended effect. It's actually an adverse drug reaction. And some of the side effects can be really serious too. So one side effect, for example, is Stevens-Johnson syndrome, which most people may not be familiar with because it's really rare. But essentially, if a patient has a sulfa allergy, they might be more at risk for this side effect. And what happens is their skin sloughs off, and they lose up to 80-90% of their entire skin, and the chances of surviving that are really low. So we try to think of ways to screen for these types of patients and especially prevent serious side effects like that.
Wow. Now, you've used the term adverse drug event quite frequently.
Mm-hmm.
Now, when I think about an adverse drug event, I think about the opioid epidemic and overdoses. Do you work to address these issues?
Yeah, definitely. I mean, overdosing is definitely an unintended effect of a medication. When a physician prescribes maybe 30 tablets of a drug, they're not anticipating that the patient takes the whole bottle at once, and that's, can lead to overdosing. But I think the opioid crisis, especially here in Houston, is a huge problem. There's a lot of drug diversion. So basically, you'll have patients that are going to the physician that are in legitimate pain, and they'll get a pain medication, but maybe they have an addiction, so they'll take too much. Or maybe they're not in legitimate pain and they're selling it on the black market. That's where the drug diversion comes in. And surprisingly, a lot of, or not a lot, but more physicians than what you would think are actually running like quote unquote pill mills. They will just give opioid medications to anyone that comes in, and that's kind of contributing to the problem. DEA is trying to shut those down. And the problem with opioids is one of the side effects is it can cause respiratory depression. So that's why taking too much of it can cause death. And that's part of the high rate of ADEs is because of overdosing. But a patient intentionally causing themselves harm is not necessarily something that a healthcare professional might be able to anticipate when they prescribe it. But there are ways to screen for, looking at the patient's history. Have they been suicidal in the past? Do they have an addiction history or an addictive personality? Do they have a history of using illicit drugs? Maybe these patients should get a non-opioid painkiller. So that's one thing. And then when you say overdose, intentionally taking too much is one thing, but then on the flip side of that, it's starting a patient at a dose that's too high. So physicians use kind of clinical algorithms to prescribe patients medication, and a lot of times these medications are prescribed to the best of their ability, but if patients aren't getting this type of pharmacogenomic testing to understand how their body metabolizes drugs, then they may be started at a dose that's too high for them based on their genetic background too. So that's another issue that we also focus on.
This seems like really important work. Now, how can people get involved with the organization?
There are a lot of ways to get involved. One way for healthcare professionals, we invite you to join our network, join our mission. If you really have a strong background in pharmacovigilance and you really want to get involved, we're also looking for people to join our leadership team. So definitely feel free to reach out to us if that's you. If you have an interest in medical literature, or you've worked as an editor for a medical journal, for example, maybe you'd like to help us start our open access journal in pharmacovigilance. And if you're not in healthcare, but you're a patient that's experienced serious side effects and you want to tell us your story, we'd love to hear it. We also have a blog that we have a variety of different people write for the blog. So we'll have doctors, pharmacists, but also patients who have experienced side effects. So if you want to write about your experience with that, we would definitely welcome that. And also, since our organization is a 501c3 nonprofit, we also invite you to reach out to us about sponsorship opportunities, and especially if patient safety or drug safety is something that your organization focuses on, maybe just think about us during your next round of charitable giving.
Absolutely. Now, where can people find out more information about ASP?
Sure. Well, so you can check out our website. It's www.stopadr.org. And you can also email me directly. My email address is sarah@stopadr.org, and I'd be glad to provide you some references or supplemental material to tell you more about the problem as well. So
That's all excellent information. Thank you, Sarah.
thank you. Thanks for having me.
Of course.
Quite an honor.